Good afternoon and welcome everybody. Thank you for coming to the inaugural lecture of Global Health and Development. I believe the newest team at Imperial College. So my name is Ryan Lee. I'm advisor for the Global Health and Development team. And our team, well, we specialize in global health and development. Under the Institute of Global Health Innovation, led by Lord Aradazi. So our flagship project is the International Decision Support Initiative, IDSI, funded by the Gates Foundation and the Department for International Development. And our aim is to help decision makers around the world, particularly in low and middle income countries, to use evidence to help them make better decisions for better health for their populations. So I'll introduce the chair of IDSI, Professor Tony Collier, who will then introduce our very special guest speaker. So let me hand over to you, Tony.
Thank you, Ryan. Do I have to wear this? Or I just hold it? Oh, this is for the recording?
Yes.
Okay, fine. Well, welcome. It's wonderful to be here. This is the second day, I think, on which IDSI has been amongst you all. And I hope you're going to make my colleagues, I'm sure you will make my colleagues very welcome. They're a very multidisciplinary team. They're very committed to multidisciplinary approaches, and discipline and evidence and hard thought are their hallmarks. They're a wonderful bunch of people, and I think you're actually very lucky to get them. And nice international is the poorer for not having them at 10 Spring Gardens anymore. It's my pleasure and joy to be the chair of this small group of 10 people, a talented group, and I hope to be able to continue to enjoy being their chair for at least another few years. We all have heroes. In the world of public health, that we can name lots, but I don't want to be specific about public health. I want to talk about health service building in general just for a second. And I think one of the heroes that in the UK we would all look to would be Nye Bevan, as essentially the creator and founder of the National Health Service, which is in a way an embodiment of the whole principle of universality and comprehensiveness in the delivery of healthcare, free at the point of consumption. And I don't think it's too much of an exaggeration to say that Suwit is the kind of Nye Bevan of Thailand, where the creation of something that isn't quite as obviously as advanced and comprehensive as the NHS, but it's damn well getting there, is quite a remarkable achievement, particularly when you think of the rather difficult political climate. Here was a young doctor who was started out his career in the borderlands of Thailand, amidst poverty, where there wasn't another medically qualified person within 100 miles, who learnt about hardship and medical deprivation the hard way, and and went on to be quite determined to do something about it, along with one or two other key colleagues. But the general environment in Thailand, of course, has never been particularly conducive. I mean, it's essentially a series of military governments, very unstable political situation. And so it's not surprising that a guy that manages to achieve what Suwit has achieved, and I hope he's going to tell us a little bit about how it all happened, is a guy who is not only witty. Most survivors turn out to be quite witty people, with good turns of phrases, in English as well as in Thai, I might add, but also very wise. And one of the things that, one of the bits of wisdom that I've sort of noted about Suwit is a very important lesson for all of us, I think, which is that in order to achieve great things, you don't necessarily go directly for them. You have to be patient, you have to work hard, and you're flexible. And that's, I think, the story, at least a part, an aspect of the story. There's a rather nice little book written by somebody sitting in this room. Benji, stand up so that everybody can see you. This little book's called The Star in the East. And it's the story, partly of the development of you can sit down. Partly the story of how healthcare developed in Thailand, but it's in particular a story of HITAP, the Thai equivalent of NICE, and the influence that this man has had in its creation and in the training and development of the two stars who actually lead it, in particular Dr. Yot, who has created HITAP and has been its director, no, doesn't like that word, is the leader since its inception. So there's that little book I recommend for those of you who want to know a little bit more about how things happen there. Anyway, it's a great privilege to have this clever, witty, and brilliantly brilliant manipulator of events to talk to us tonight. So, Suwit, come on and tell us your story.
Good afternoon. Thank you, Tony. I have here. Thank you for your propaganda. I felt very humble here today. As soon as I walked into Imperial College, I saw my, like past hero, Alexander Fleming, second floor of that building, found penicillin. It reminded me that next week I have to be in New York for the UN General Assembly to accept the monumentous political declaration on antimicrobial resistance. Imagine just more than 100 years ago or something, when Alexander Fleming first encountered an antibiotic. And now we are in the era of nearly no antibiotic to use. Your global health and development should not focus only on economic evaluation, but also real global health and development. Antimicrobial resistance is one. And when I came into this room, Tony made me even more humble. As a runner myself, I saw this man who ran 1 mile in less than 4 minutes. 1 mile in less than 4 minutes. I can do 1 mile as well. This morning, when I arrived, I went jogging in Hyde Park. I did 1 mile in 10 minutes. This man, 4 minutes. Now, you all may not, some of you may be familiar, some may not be very familiar with the universal health coverage in Thailand. Universal health coverage is one of the sustainable development goals. And we fought hard before we can get it onto the SDG. Not everybody feels that it should be on the SDG. Unbelievable. I'll be very brief. I want more interactive. But actually, when I talk, if you have, very burning question, don't hesitate to ask. Okay? Next, please. This is us. I want you to see the third bullet point. Questionable democratic with constitutional monarchy. We have so many military government in the past. We don't like it. I, for one, don't like military government. But believe it or not, every time we have military government, it's the best time for health development, health system development. I'll tell you why. Even with this military government, okay? So we are middle-income country. We have universal health coverage since 14 years ago, which means 100% population coverage of almost free medical care. I think we pay less than the British to receive medical care. In your case, you get the prescription, right? You go to the pharmacy and you pay for each item. In our case, we pay nothing. We pay nothing, pay zero. We don't have to pay for any prescription. Okay. Next, please. And here it is, universal health coverage. Not only financial, without financial barrier or medical bill, poverty for medical bill. Usually when we talk about universal health coverage, we usually talk about financial protection. But the upper one is more important. Free service for bad service or no service is useless. Many developing countries, you go, you see free service, government announced free service, everything is free. But when you go to the hospital, you go to the health center, you see nothing. No essential drug, no equipment, no good service. So the top one is most important. Universal access to essential comprehensive health services. From health promotion, disease prevention, treatment, rehabilitation, long-term care, and palliative care. All now in Thailand. So our universal health coverage does not cover only treatment. We are not just health insurance to insure for financial protection against catastrophic medical bill, but we include health promotion, disease prevention in our universal health coverage. You may ask, is this a stupid idea? Because usually when you say health insurance, you insure against high cost. For us, we insure from first dollar to last dollar. You don't insure health promotion or disease prevention. Vaccination, everyone need it. There's no need to insure. But in our case, we insure everything. From $1 bill to, we have the maximum bill maybe $100,000. Drug for a very rare disease called Gaucher disease, Imperial is $100,000 per year. It is included in our benefit package. Hemodialysis, peritoneal dialysis, everything free. Next, please. Here, X-axis, population coverage, universal. Financial protection, essentially no prepaid, except about 15% of the population who are formally employed. They pay 1.5% of their payroll, below 15,000 baht, which is very low. Above 15,000 baht, you don't pay anything. 15,000 baht is what? $250. If your salary is above $250, you pay 1.5% of $250 for that. The rest of the population pay nothing except tax, value-added tax, income tax. When you go to get the service, you pay nothing. You pay nothing. If you receive the service, so-called essential drug and service in the benefit package. If they provide you above that, literally they cannot charge you because you are insured by the government. Okay? Depth of service, as I mentioned, from everything. Essential drug, you may feel that, we may have a few items. We have around 800 items, essential drug. From paracetamol to what I just told you, Imperial, which is $100,000 a year drug. Okay? Even dentures, you get free. Dentures for elderly. Dental service, free. Not for cosmetic, of course. Cataract surgery, coronary bypass graft, some organ transplant, like kidney transplant, liver transplant for biliary atresia. These are all free. Bone marrow transplant for some diseases, all free. Don't ask me how can we do it, but with the upper middle income country like us, which is only $6,000 per capita per year of GDP. $6,000 per capita per year of GDP. We achieved universal health coverage when we were only 1,900. Next, please. It's a long story. It's not, immediately from 0 to 100. We gradually start from $390 per capita in 1975. We start to cover the poor. Who determine who is poor or not poor? Initially, it's me. Me mean I was the doctor at the hospital. When patients come in, I look at them. I charge them. No, there's no cashier anything at that time. I'm the one who charged them. When I write the prescription, I look at the first. Oh, this one is rich. Oh, this one is poor. Oh, get low. And then they go to the pharmacy and pay. Pharmacy of the hospital and pay. If they don't have money, they come back to me. I charge them $3. They may, oh, doctor, I have only $1. Okay, $1. I'm like God, determine everything. No one there, only one doctor. That was 1975. And we gradually increased our coverage. Until 2002, we have universal health coverage, 100%. Look at the vertical axis. It's the GDP per capita. It is at the bottom, the worst situation of economic crisis. Whenever we have military government, whenever we have economic crisis, we have improvement in the health system. This is Thailand. I'm not saying that it's a rule, but it's our experience. Okay, so universal health coverage is not immediate, it's gradual. Okay, and at the bottom of economic crisis, here, around this time, we introduce more coverage. When we have economic crisis, early 1980, with two oil shock, and it's the first time that Thailand has to take loan from IMF. Zero growth of government budget for 5 years. Zero growth. But we increase the coverage. Next, please. See, you need to build good health system. EQE, equitable, quality, efficiency, efficient health system. So every district, a district is about 30,000 to 80,000 people. We have a hospital. At this moment, 30 to 120 beds. At each health center, at each community, we have a health center, or more, sometimes more than one health center. The most important thing is committed health workers. You can have hardware, can have building, but if the health workers there are not committed, you go nowhere. So since our early days, we use the policy of rural recruitment, local training, and hometown placement. Our nurses are recruited from the rural area. They compete in their own province, in their own district. And they study in the provincial hospital in their province. We have nursing college all over. And when they graduate, they go back home to work. They have to work for us for 4 years. Compulsory public work. Okay. I want you to look at the bottom, the last paragraph. A bold decision to freeze capital investment in urban hospital for 5 years. This is in early 80s. Economic crisis, two oil shock. Zero growth of government budget for 5 years. But the government, the then military government, determined to build rural health infrastructure. I can see by my own eyes because I was there. I used to work in a very old-fashioned small building. Suddenly my building become new. All the equipment comes. I used to receive only maybe $1,000 a year. $1,000 a year of budget for drugs. $1,000 a year, it's true. It increased to 10,000, 30,000 in a few years because of this policy. In spite of economic crisis and 5 consecutive years of zero growth of budget, even negative growth, the military government was very bold to freeze all the capital investment in urban hospital in Bangkok and in big cities and pour all the money into rural area. Imagine who are the doctor of this big chap. They are the doctor in the urban area. But they are the one who convinced the big chap, the military government, to do this. Next, please. And you can see the upper line is the rural budget. Lower line is urban budget. 1983 was the first time that the rural higher than the urban. You have to understand that most people in Thailand live in rural area, okay? Because of that policy. Next, please. And you see all these facilities sprang up in Thailand. I used to work in one of this one, hospital like this. Of course, I'm still the only one or two doctors there who have to do everything from pediatrician to anesthesiologist. I have to anesthetize my patient, go out of the operating room, wash my hand and come back as a surgeon. And my midwife report to me every few minutes, the pupil size, the pulse, and blood pressure while I was operating. This is the fact. You have no choice. You have no choice because you are the only one doctor, a GP, a surgeon, everything. So this is essential for universal health coverage. Not just free service, but real good service. Next, please. You see the change. This is the big change. 1977, before that policy, most outpatients go to urban hospital. You see a reverse triangle, right? After that, you see upright triangle. Most people go to rural health center. And the base of the upright triangle expand. Of course, even now, if you go to urban hospital, you still see crowded. Because you look at the bracket, 5.5 million people, now 18.1 million people. Visits. The demand increased. So even though we expand rural health center and district hospital with more popularity in services, hospitals are still crowded. Okay? Next, please. We need more resource. Where do we get more resource? Apart from that policy, after that, because of peace, the military government was able to keep peace with the communist guerrilla in the jungle. The peace reduced the proportion of security budget. At the same time, we moved from import substitution to export-led economy. We have double-digit growth for many years. The government paid off all the public debt. The proportion of government budget to public debt reduced. And we have huge fiscal space to spend on infrastructure, health, social welfare, and education. Our government budget on health increased from 5% to 13% to 16% this year. 16, we are not the top. I understand that Japan may be the top, around 30% of the government budget on health in Japan. We are 16%, but 16% is already very, very high. Maybe in the 85, 90 percentile around the world. We create a sin tax. We collect 2% additional levy on tobacco and alcohol excise tax. We don't ask the finance ministry to collect excise tax and give 2% to us, no. They keep their own 100% excise tax, but they collect 2 additional percent for us. This makes them happy because they don't lose any money. They still keep their excise tax, 100%, but they get 2% additional money for us and put into a public foundation called the Thai Health Promotion Foundation for health promotion, not only tobacco and alcohol. This is the, I mentioned this because it was the one who created HITAP, where Tony mentioned about this book. If you go to the website hightap.net, you can download it. You don't have to buy it, and you don't have to carry it. Too heavy. Okay? And HITAP play a very important role in economic evaluation to help us to determine which new technology, which new drug should be included in the benefit package of universal health coverage. HITAP is not like NICE. They are more clever because they determine that we don't want decision authority. We only generate evidence for those who make decisions. So they are not at risk. No one wants to attack them. They got some attack sometimes, but because they don't have the authority, they are clever. So they survive so far. We have community universal health coverage fund because we know that the central government money is not enough. So our universal health coverage gives money, about $1.5 per head per community. So if you have 5,000 people in your community, you get $7,500 per year, with the condition that the local government unit, elected local government unit, has to put in another around $7,500. So you have $15,000 a year for public health activities. A year, not forever. This may be small, but in a rural community, it's not small. They can do a lot. Many of them cannot, absorb all the money. Next, please. And this money also go to support long-term care and palliative care in the community. You see from this, as I mentioned, security budget, about 20, you look at 1985, the turning point, about 25%, gradually down to 13%, 12% fiscal space from reduction of security budget, not reduction, the nominal value, nominal figure still increase, but the proportion come down. And you see the public debt, 1987 is 24.7% because of economic growth, come down to 5% and go up again. And health budget go up, both in terms of proportion and nominal figure. Next, please. And this is the result when you have universal health coverage. Household prevent from medical impoverishment. So medical universal health coverage not only responds to the third goal of sustainable development goal, it actually also responds to the first goal, poverty eradication. Those who are just above or above poverty line, if you don't have universal health coverage, when you get sick, you immediately come below poverty line. Okay? Next, please. And access increase both inpatient and outpatient. This is very brief. This is front office. You see what we have done, what we achieved. Now I'll go to the back office. What behind the scene? What challenges we have faced before we come here? Usually no one asks about this question. But Ryan, he said, no, we have listened a lot. We have heard a lot about your front office. Please tell us something behind the scene. What are the challenges before you can come here at this point, and the challenges for the maintenance of the universal health coverage? It's like the challenges before you get national health services, and the challenge to maintain your national health services is more or less the same. Next, please. 5 big mountains. We use the word mountain. It's come from the Chinese story. An old man moved the mountain. A stupid old man moved the mountain because the mountain blocked the road from his village into the city. Just 2 kilometers, but he has to walk, 20 kilometers. And he determined that if he can build a road 1 meter a day, just 1 meter a day, in 6 years, he can reach the village, he can reach the city very easily. We call him a stupid old man move the mountain. So we use this. There are so many challenges, but I just summarize into 5 big challenges that block the way towards universal health coverage, and also challenge us now to maintain the universal health coverage. Next, please. These are the 5. I'll go one by one, very briefly. Next, please. As I have told you, it moves slowly. The first time that we start universal health coverage was in 1975. 1975, right after the military government. There was a student riot, student demonstration. I was one of them. Millions of people on the street to chase the former military government out. This was in 1973. And we have the first elected government in 1975. The government, elected government, the first one, democratic government, want to please the people. So we have free bus, free education, and free healthcare for the poor. For the poor. That was the first political commitment. Gradually move. It's not come from the top. Actually, it comes from public health leaders. We have good ancestors. I was not there. I was still a young, medical graduate from nowhere. They are champions of universal health coverage, and they build more and more people. We learn from our history that if you want to create something new, you need a senior, charismatic person and a junior, very energetic person to work together. The senior people will bring in all the social, intellectual capital and even mobilize funding to support the junior people. But he or she is too old to not that much energy now. You need energized young people like many of you here. So if you want to do something good, go find an old man or an old lady, a senior lady. If you can impress him, you'll be successful, because he or she bring in wisdom, social capital network, which bring in financial capital for you to work. Okay? So public health leadership is very important. They are the one who bring in political commitment. In the year 2000, when we have an election, it's the first time that political parties start to use policy for their campaign, not just only to give the money to buy vote, but real policy. One of my colleagues, Dr. Suwit, he passed away. I'll show you his picture. He was the champion for universal health coverage, the real champion. He sold the idea. At that time, we already achieved 71% population coverage. He sold the idea. I joined him as well, sold the idea to all the political parties. Only one political party bought the idea. Very brave, because you have to find more money. It's only $250 million additional budget that was told by Dr. Suwit to all these politicians. They know nothing. They just want vote. Okay? They said, oh, $250 million. It's nothing. Okay, go ahead. But we'll not call it universal health coverage, because people don't understand universal health coverage. We'll call it the policy 30 baht treat all disease policy. 30 baht then was $1. So his policy, the policy which he sells to the people is $1 treat all disease policy. It was very popular. And he, with other populist policy, he won a landslide election and become the prime minister Unfortunately, he is now in exile. He used to live here. Anyway, but he was the one who dared to commit. And because he's from business, those who are from business know how to implement policies. Politicians who are not familiar with business, sometimes they have only idea, policy, but they don't know how to implement it. Okay, political commitment come from champion, come from evidence, like the decision, the military decision to shift urban hospital budget to rural area. Our ancestors, public health leaders, show them the evidence. Primary care is much more efficient, cost-effective than secondary, tertiary care. And you, the government, the military government, you are facing the challenge from the communist guerrilla in the jungle. They are the ones who are very close to the rural people, which are majority of the people, and they spread all over the country. If you want to fight with them, eradication of rural poverty is the must. And one of the measures is to build rural health infrastructure mandated by committed health workers. So the evidence and the champion convince the politician. You want votes, you want popularity, you want to fight with the competitor, you come to us. Active citizen involvement win over the politician because they want popular support. If we, as health people, go by ourselves, not much power, not very powerful. But when you bring in all the people, so the National Health Security Bill, NHS is not National Health Service, it's National Health Security Bill in 2002. It was the first time that our constitution allowed lay people to submit a bill to the parliament. You have to collect signatures of Thai citizens, 20,000 of them at that time. If you have 20,000 signatures of Thai citizens, you can submit a bill to the parliament. And this was the first bill to go with the constitution. And actually they were able to collect 50,000. Not through internet, just click and sign. No, at that time there's no service like that. You have to go one by one and collect their signatures. And they have to give you their ID card, photocopy of ID card signed. It's a laborious movement, it's not simple. And what happened to this? The government has to consider, the parliament has to consider the bill from the people. And the government has to propose another draft bill in parallel. When it goes through the first reading, representative of those 50,000 people join the special commission of the parliament to consider the bill, article by article. So the bill reflects the demand of the people. And with that, out of the 30 members of the Universal Health Coverage Board, there's a board, the Universal Health Coverage Board managed $5 billion a year budget for universal health coverage. People has the civil society representatives have 5 seats out of 30 board members. I'm one of them, representing the elderly group. There are 9 groups of civil society. You have to have 9 representatives. And 9 representatives choose among themselves 5 people to sit on the board. So the people has representative in the governing structure. They feel that they own the system. And this is how political commitment come in. And we have to be opportunistic, as I mentioned to you. Election, whenever they come election, politicians will come and ask you, but they know nothing. They come and ask you, what I can sell to the people. Please give me idea. So we have to have many things in our pocket ready to sell. That That is what we did. And even military regime, they want to have public support. Military regime cannot survive without public support. So they also ask for new idea. Like this regime, they ask for new idea. We sell them family healthcare team. Each family must have one team of health, like the US, like the UK system. You register to a GP, right? So we sell to them, and they immediately, bought it up, and then we help them to implement it. So although we don't like military government, we are opportunistic. Okay, next please. These are the champions. The one in the black, with this one. This is Dr. Suwit. I call him the father of universal health coverage in Thailand. He dedicated his whole life. And you see this man, Professor Sen, old man. See, if you want to do something successful, you need charismatic old man. That's why I invite Tony to be the chair. Tony, you are old enough to be the chair. Too young, you cannot. Okay. This man is he was a fighter. In Thailand, public hospital has a user fee system. Even with universal health coverage, I say you don't pay. Actually, you pay if you bypass the referral system. If you are registered with this hospital and you want to go to that hospital bypassing this hospital, then you have to pay. Some people do pay. Okay? He was the one who started the user fee system in Thailand more than 70 years ago. In those days, everything is free, but there's nothing. He was a director of a small provincial hospital. The situation was worse than the district hospital nowadays. He was there, he has nothing. Like me, $1,000 per year of budget is not enough. So he meet with the community leaders. Building is old, no money. How can we do? The community leader said, "Oh, don't worry. We'll collect, 25 cents. Oh, no, not 25. 1 baht is much less than 25 cents. Maybe 3 to 5 cents from each of the people in the province, and we'll build a new hospital for you." This is in Chiang Rai, where the Golden Triangle is. If you don't know Chiang Rai, you must know Golden Triangle. That's a province where the Golden Triangle is. And they built a big new hospital for him. So they call Chiang Rai People Hospital. Then he said, "I still don't have money, the money that I got from the government only pay for the salary of few staff. I need more staff to do more. I need more money for drug. Doctor, why don't you collect fees from us? Because when your drug are gone, you only write prescription for us, and then we have to go to the private pharmacy to buy it anyway. We have to pay it anyway. Why don't you charge from us? We are happy to pay those who are poor. You don't collect them. You don't charge them. Those who can afford, you charge them." So he started to charge user fees and keep the money and buy drugs, hire more people. The story was heard by the Minister of Finance in Bangkok. This was about 800 kilometers from Bangkok. 70 years ago. No good communication, no good road. The then Minister of Finance was furious. He came to the province. "How can you do this? All the money that public sector collect must come to me. Central government budget. And if you want budget, I'll give it back to you." Not the same amount, of course. He demanded the doctor to send all the money. The doctor summoned all the community leaders. Your Excellency, you talk to these community leaders. They are the one who asked me to do this. The community leaders explain to the minister, hey, this hospital, we build it ourselves, you give us nothing. All the staff here, half of them are hired by us, our own money. How dare you collect our money back? We won't allow you to do that. After some good discussion, the Minister of Finance went back to the ministry and issued a ministerial order. From now on, every public hospital can collect money and keep them there. He also sent his Comptroller General Department staff to design a simple accounting system. It has to be accountable and transparent. You cannot just keep it in your pocket and then use it, right? This is the first person, and he was the one who persuaded the military government in 1980 to freeze investment budget in urban hospital. He was then the director of the National Hospital in Bangkok, Central National Hospital in Bangkok, Ratvithi Hospital now, but then he was the director. And the government picked it up. So you see, these are champions from, these pictures are mostly people who work many years in rural area. They are like rural warriors. We call them rural doctor. Next, please. And the old, there's more picture, no? Okay, I'll show you more picture of more people. These are just a few. So it's not just someone who is a hero and do everything. It's a group of people. Provider dissatisfaction is big headache even now. Because the relationship changed. Previously, like I said, I'm like a god. I'm the only one doctor. Take care of 200,000 people in 3 districts. Everyone come to me, do like this. No matter how old they are. I was mere 24, 25 years old at that time. But when economy grow up, with universal health coverage, people feel that this is my right. I'm not begging for service from God anymore. This is my right. You are providing service. And the doctor feel not that good. I used to be a god, Now I'm just a lay person equal to others. They feel bad. Don't blame them. This is their normal people. So we create, and more also, we create a no-fault compensation system under the National Health Security Bill. Up to 1% of the 5 billion will be deducted to pay for no-fault compensation. But usually we pay less than 0.1%. So that they come to claim when they have a problem from services. Provider also on the governing structure of the National Health Security Board. We have provider there as well. People say, hey, this is conflict of interest. We need a provider purchaser split. Why you have the provider there? Well, this is a Thai system. We compromise. They are there. So in the board of universal health coverage, every month when we go to the meeting, it's like a small battle. Every month. No solidarity. 30 people divided almost equally into 2 camps. In the past few months, we have to elect a new Secretary General. We have a selection committee. The selection committee proposed the name. And they come to the board. The board has to vote. Just one vote win over the other camp to reject the proposed name. He filed a lawsuit in the administrative court against the board now. I was on the side that support him. So I told him that, hey, please don't sue me. You can sue author. Most important is the committed providers. We need to make the provider committed. We are lucky that we have a father of modern medicine and public health in Thailand, Prince Mahidol. Next, please. This is the 3 mottos that every health professional memorize this by heart. The first day that you enter into medical school, nursing school, pharmacy school, you are taught these 3 mottos. Particularly the last one, put the public interest first, self-interest as second. It doesn't mean that every doctor is dedicated. No. But at least majority of them are not that bad. That's why in Thailand, 75% of the doctors work for the public, 25% work for the private. Okay, not like UK. UK most in the public, but in our country we have 25%. Next, please. The oldest medical school in Thailand, Sri Raj Hospital, since more than 40 years ago, give an annual award for outstanding rural doctor. And this doctor will be invited to give a keynote address in the oldest medical school to the lecturer and all medical students. This is a big inspiration. And every doctor who work in rural area feel that this is the most prestigious award. I'll do as much as I can so that one day I can receive this award. Next, please. Please go back. I want you to remember this face. A mad doctor, I call him. Next, please. These are some other rural doctor. Next, please. This is the border of Thailand to Myanmar. Mountainous area. Lots of fighting between the minority group, ethnic group of Myanmar, the Karen and the Chan. There are 4 doctors who work there for more than 20 years. Next, please. Go. This man, 32 years. This is the most difficult area. That's the man I show you. This man is he's a madman. He crossed the border to Myanmar. Built 2 health posts there. Very popular, very nice, well equipped. And he brought the people to train in his hospital and deliver the service there. He said since the first day that he did that, tetanus neonatarum gone, obstructed labor gone, infected labor gone, malaria well under control. I asked him, I visited him, I visited the 2 health posts. Did you get permission from provincial health office? No. Did you ask permission from the health minister? No. Did you ask permission to the Myanmar government? No. Why? How can you do that? If I ask, I never get permission anyway. I go ahead and do it. Then I talk to the health minister of Myanmar. Hey, there's 2 health posts here. You know? He immediately called his staff and looked at the map. And then he said, oh, Dr. Suwit, those are the areas that we never reach because those are controlled by the minority group. I asked him, where did you get the money to build it? My hospital money. That's why his hospital account is always in red. We have to mobilize lots of money to help him. Madman. 25 years already there. Next, please. This one, 14 years, and there's another one, young, 9 years. He determined, I visited him, the young doctor. I asked him, how long will you stay here? Oh, I have no plan, but I have no plan to move. You need more of this, not only doctors, nurses, pharmacists, dentists. We have more and more. Not all of them, of course, but there are more and more and more. hundreds or thousands of them all over the country. This is the backbone of universal health coverage, not the money. Money only creates troubles. No money, $1,000 a year. How can I survive? I went to the temple. Temple is the richest place in Thailand. Rural doctor go to the temple not to donate, to get money. And the chief monk always support us. They do everything to get the money for us, to build hospital, to build central oxygen pipeline, to supplement the drugs. So we don't depend only on central government. Next, please. Power struggle because of money. The fight between National Health Security Office, who control $5 billion, and the Ministry of Health, who used to control the money, but now they don't have money anymore. Their budget is actually I am from Ministry of Health. Ministry of Health budget is only 1/3 of the National Health Security budget. Also brain drain. Good people cannot tolerate vertical bureaucracy in the ministry. They move to the National Health Security Office. They move to the Syntax Thai Health Promotion Foundation. So we are losing social intellectual authority. Although we still have political authority, but social intellectually we lose. Next, please. Sustainability. This is a big question. 16% of government budget on health now. It's a big question. Sustainability. Democratic vs military government. People feel that this USC come from democratic government. So when military government came in, it should be destroyed or abolished. But on the contrary, we survived 8 government, 17 health minister. And when we analyze back, it was the military, we have two military prime minister out of 8. It was during these 2 military prime minister that we got the most highest increase in sorry, allergy. Highest increase in budget to the universal health coverage. The first set of government who start the universal health coverage give the lowest budget. They are very clever. They get all the credit, but they give little money. But the military government, when military came in, people asked, are you going to abolish USC? Oh, no, we'll maintain it, no problem. But people don't believe them. So they have to give more money to show that, we are really committed to universal health coverage. Lots of management hurdle, payment methods. We do like the UK. We pay by capitation to provider. Provider are not happy. But
was it right that the military government also got rid of the copay? I think where was it started with the baht?
Well, the previous military government got rid of the $1, and then when the democratic government came in, they reinstated it. But they have 21 category of people who are exempted. After all the exemption, the hospital collect little. So many hospitals just don't collect it. It's a big hurdle to collect only $1 and get little money and have to exempt 20 category of people. Okay? But when we come back to this new military government, they didn't do anything on this. Okay? But they also create some difficulties to the universal health coverage. Accusation of corruption, this and that, they fire the Secretary General. But after almost 2 years of investigation, they found no evidence at all for corruption. So it moved on quite okay. And in spite of the fact that the government budget was cut or increased very little, universal health coverage budget increased more than all government budget. Okay. Next, please. This may be the one that fit with Ryan Global Health Development. Evidence. We need huge evidence to support the implementation and assess the situation. We still face huge challenges. Without evidence, we cannot move. So we institute many evidence generation agency, Health System Research Institute, International Health Policy Program, Health Interventionary Assessment Program, Health Insurance Research Office, and university, many. Every decision we made, we ask for evidence. Okay? So this is your job, Brian. And we need to link to policy decision. That's why all these agencies link to the board members of universal health coverage so that they can inject the evidence to the board to make good decisions. Next, please. And that is the experience from Thailand. In conclusion, when we face difficult social problems, we always come back to these triangles that move the mountain. We need knowledge. We have so many institutes to generate knowledge, mainly system knowledge, not biomedical clinical. We also have biomedical clinical research, but we are talking about system knowledge. These people, they are champions, linked to politics, influence politics with evidence. And they also work closely with people, move the people, and the people move the politics. Okay? Next please, the last one. We also learn from Malcolm Gladwell. This is triangle that move the mountain to move important, difficult issues. But we need to have three groups of people. Stickiness of the issue, conducive environment. Like when we start universal health coverage, we don't say universal health coverage. We say $1 treat all disease. It's immediately stick into the heart of the people. See? And we have three groups of the people. The Marvin who know everything, the connector who connect people, the salesman. Dr. Sangwan is one person that has three characters in one. That's why he is the father of universal health coverage in Thailand. And the conducive environment, the political situation at that time, support universal health coverage. Okay? I hope I tell you more enough. The back office, usually people don't talk about this. They talk about the first 10 slides that I show you. What are the coverage? What are the benefit package? How do we pay? What are the outcome? What have we achieved? But the 5 challenges are the back office. Any question, or you feel you have enough? Oh, lady first.
Yes. Sorry.
Hi, I'm Sophie. I'm with Department of Health and actually working on the Fleming Fund. For those of you who don't know, the Fleming Fund is a £265 million fund to try and address antimicrobial resistance in low and middle income countries. I have 2 questions. One is if you could say a little bit more around the sustainability issue, particularly any sort of public health interventions. So in the UK, certainly one of the key challenges for the NHS going forward is around aging population, obesity, chronic health issues, those sorts of things. Second point, I'd be really interested to hear your views on AMR.
The things which is always, we analyze a lot of the work from Thailand. The things which is remarkable in rural areas, especially the development of primary care, was not achieved in urban areas. Is it because of that blockage which you did in the 80s, late 80s, early 90s, i.e. Frozen the resource allocation, although it was for hospital capital, but presumably this one did have an impact on primary care development.
Okay. Any more? Let me answer these 2 first because my memory is short. Sustainability. There are many concerns, and some people start to propose cost-sharing mechanism to mobilize more resources. The last minister came to me and tell me, Suwit, I'll appoint you as a chair of a commission to see how we can collect more money, cost sharing. I said, wait a minute, sorry, I won't accept that. Once everyone know that I chair this, so many shoes will come from the air into my head. No one like cost sharing. So if you want me to do it, I would frame it as a commission to look at resource mobilization for universal health coverage. And in 4 months, our commission came in with a report called SAFE report, S-A-F-E, SAFE, Sustainability, Adequacy, Fairness, and Efficient. You cannot have only sustainability. You need to have adequate amount of money, fair financial contribution, and efficient use. Not only more money for health, also more health for money. And we have all the measures that we propose. They are, after my commission, a new minister came in, he appointed another commission to bring my commission into action. They are doing it now. So how can they get this report? You have the report, it's in the website of IHPP, okay? It's available in the website. I think you can read it. I don't want to get into the detail because it's not only collect more money, it's about everything, comprehensive package for sustainability. Now, AMR, I have one most important view. Action, because globally, we have a World Health Assembly resolution last May with a global plan of action. But in our view, in my view, actions without planning is much better than planning without any actions. Actually, we have just approved last month, August last month, yes. We just approved a national strategic plan on AMR, the first one, and we are going to distribute it in the UNGA. I said to my minister, we must distribute it there for the image of the country. But actually, we have already implemented 60% of those activities in the strategic plan. And it is not just health sector, animal sector, agricultural sector, many other sectors has to work together, public and private. It's not an easy one. Each of us individually can contribute to reduce the AMR. Wash your hand very frequently. Exercise to keep fit, immunity go up. When you have good immunity, you don't catch cold, you don't get infection easily. Or even you get infection, your body can control it. You can do individually. Don't wait for the government. Don't wait for Sally Davies, my good friend. She is one of champion on AMR. But she herself cannot do much, not only mouth, only talk. What she can do is to wash her hand herself and do more exercise, which she resists to do it. I convince her all the time. Now, come to your question. Urban healthcare services is a real challenge because in urban people don't have strong community tie like rural people. We do have urban health center, but this urban health center do more passive services than more active service. Unlike the rural health center, they have outreach, they move out. We have, I forgot to tell you, we have 1 million, actually more than 1 million, village health volunteers, more effective in rural area than in urban area. For our long-term care, we are an aged population now. We are going to be super age in the next 20 years. No, actually, next 14 years. Super age. and we need long-term care. Universal health coverage start the long-term care this year, this fiscal year, with only $17 million budget to cover 100,000 frail elderly. We determined from the first day that we will not pay for institutional-based care. No, we will not go in that direction. We will support only family and community-based care. So we train carers from these 1 million village health volunteers, those who have experience to take care of the elderly. We bring them in voluntarily, train them for 70 hours, and they provide supervision and also services to frail elderly. The main carer is the family member. Okay, so your question is perfectly right to the point. We have big challenges in the urban area. We are trying to move towards family care team. It's not easy. It's not easy because urban people, well educated, they don't allow you to get into their house easily. It's not like rural people, you are like friends. So you need to build community. And the relationship should change. Previously, vertical relationship between provider and people, and now become contractual agreement. We wanted to move into so-called communitarian relationship, where the people and the doctor and the nurses know each other very well, like people who live in the same village, in the same community, they are friends. It's happened in rural area, start to happen, but not in urban. We need more time.
But could be there may be another facts, so which maybe there is another fact which you are brushing it aside.
Yes, please.
Which is the private sector, and the influence on the private sector in the urban areas is so strong that preventing some of the development the government wish to promote.
I think that is part of the story.
Yeah.
But not all, because the public services, even in urban area, are quite good. Not that bad. Although you have to be in queue, but the service quality is good, the facility is good. If you go to the public hospital in Thailand, you feel amazed that, oh, air-conditioned room. Services are okay. I'm sure that better than the National Health Service here. I learned from my student who study here.
No, don't listen to them.
They have to go to the GP and usually take a few days before he or she can get appointment. One of my staff who study here, she got allergic to seafood, and she has maybe bronchial spasm. She started to have some difficulty in breathing. She called, and she got 3 days appointment. She has to go to the emergency room, right? So for us, you can go anywhere, anytime. If you are emergency, you can go anywhere, anytime. Yes, Chris.
Yeah, Ashley Grayler for the University of London. Quite interested in physical activity. Yeah, quite interested in physical activity promotion through technology. But I've got a pretty broad question, and apologies for this, but what key learnings could we best apply to this country?
For
enhancing public health.
For physical activity or for?
No, just broadly. What key learnings could we apply?
Thank you very much, Sid. You're one of the great global champions as well for universal health coverage, and it's been astonishing the work that Thailand has been doing in promoting UHC through the UN and the World Health Assemblies. You mentioned the big battles to get UHC up there in the Sustainable Development Goals, and we're aware that the Japanese and the French were being very supportive of you. Can you comment on how supportive the UK government has been in those efforts in recent years? One would like to think that the home of the NHS would be a great champion for universal health coverage, but as you've been fighting the global battles for UHC, have you found the British government so supportive?
Let me answer this second question first. In my view, what I have seen, the UK government did not resist, I would say. Did not resist. But they don't want to play the championship role. What we concern more is the US. We were lucky. It is a Democrat government. And we have Obamacare Act, right? So they cannot not support. If the US against, UK against, then you are in trouble. But those who are not happy with universal health coverage, because they are usually those who support specific vertical disease, like maternal and child health, Norway, or HIV/AIDS, TB, malaria. These people, they are afraid that universal health coverage will drain the resource from them. If you are familiar with global health through the last 60, 70 years since the beginning of World Health Organization, you see that it starts with specific disease and then move into health system during primary health care era. And then because of AIDS, it moved back to specific disease. And because of universal health coverage, health system come back. This is, up and down. It's nature. Don't blame it. But we need to work together between specific disease and health system people. Okay? Now your question, what UK can learn from Thailand? Wow, this is a $1 million consultant services. I have no idea about that. I have no idea. I cannot say that what you can learn from us because you are so mature. You have National Health Services since 1948, right? We are the one who should learn from you in terms of primary health care, GP. This we are learn from you. But one thing I think maybe is your system to bring in new technology and new medicine into the coverage of national health services. People usually say that increased healthcare costs come from aging population. It's not true. The main reason for increasing healthcare costs is the explosion of new technologies. And these are usually very small marginal benefit, but huge budget impact. We are very strict in Thailand. Even human papilloma vaccine, we drag on and on and on. We increase the pap smear coverage rather than jump immediately into HPV vaccine. We increase the pap smear coverage first. We only start this year, next fiscal year, for only 12 provinces out of 76. We have to expand it very soon. But we drag on for a few reasons. First, we want to increase the coverage of pap smear first. We don't want people to be complacent, have immunization, and we are immune now, which is not true. HPV only cover 70% of the protection. The other 30% you still have to depend on pap smear. And we drag on and on because we are waiting for the Indian vaccine to come out. But I was criticized heavily. I used to chair the benefit package committee and the National Essential Drug List committee at the same time. I was the one who tried to drag on and on and on with the support of HITAP. One of my very respectful professor, who is my mentor, wrote an email to me, criticized me very strongly. How dare you act like a god to determine the life of young ladies, young girls. I was shocked for 2 days. I couldn't reply his email. Then after I gained back my, and calmed down, I sent him back an email. Your point is very well received and respected. I myself have my daughter immunized, but I pay from my pocket. But when I chair the two committee, I'm deciding on public money, which there are so many priorities. I have to choose. So if anyone want to immunize their daughter, his or her daughter, go ahead, pay. But we are not the time yet. We don't have enough money yet to pay for that. at the national level. He didn't reply me, but I think he is okay. Okay, I think we have enough, Ryan?
Yes, so thank you very much, Dr. Suwit. Round of applause.